Dear colleagues, good afternoon. I'm Dr. Grimaldi from Brussels, and it's my pleasure to go on in this session with a talk on intestinal injury after cardiac arrest. I have no conflict of interest regarding this presentation. As you may know, the ischemia reperfusion induced by the cardiac arrest will be the cause of multiple organ failure, which are relatively frequent, as you can see in this ancillary study of the ICON large database, which show that respiratory, cardiovascular, renal failure are encountered in up to 50% of our patients, even without post-anoxic encephalopathy, and these organ failure can be the cause of the patient death. But one organ is missing here, and this is the gut. Indeed, what about it? Certainly, it is submitted to the same ischemia reperfusion, but is it sensitive to this phenomenon? Human evidence were sparse until recently. There were reports on mesenteric ischemia, which are often lethal after cardiac arrest, and some observations were suggestive of digestive bacterial translocation. Of course, gut is a difficult organ to explore. And so the easiest way is to measure digestive biomarkers that can evaluate intestinal function. One of these validated biomarkers is the intestinal fatty acid binding protein, IFABP, which is normally localized at the luminal pole of the enterocyte and is therefore absent of plasma. In case of enterocyte damage, IFABP crosses the basal membrane, as shown in the villi in the histological photographic shown in the diapositive. And it crosses the basal membrane and can be detected in the plasma. Another interesting biomarker is the amino acid citrulline. Indeed, citrulline is produced from arginine only by functional enterocytes. And then the level of plasmatic citrulline is tightly correlated to the mass of functional enterocytes. And using these two biomarkers, we perform a pilot study measuring IFABP and citrulline in 20 patients after out-of-hospital cardiac arrest, successfully resuscitated patients, of course. And you can see in green that IFABP was very increased compared to control at ICU admission, and that citrulline decreased at day 2, suggesting that there was a degree of intestinal permeability and a loss of functional enterocytes. These findings were confirmed by the group of Gaël Piton in Besançon, France, which observed the same findings, but in a higher number of patients with similar findings, high IFABP peak and low citrulline after a few days in the ICU. They were able to define critical threshold of these factors, and you can see on this table that patients that were higher than this threshold had a better prognosis than patients with both biomarkers severely impaired. What are the consequences of this intestinal injury? We get further in our study measuring endotoxemia during the 3 first days of ICU stay. And we observed, as shown in this dot plot, that endotoxemia level was clearly correlated to the level of intestinal biomarkers. The more the biomarker was abnormal, the highest the endotoxin was, suggesting indeed that the endotoxin came from the intestine, which is quite logical. To get further, we performed a study on post-cardiac arrest endotoxemia that was published in Critical Care Medicine in 2015. We enrolled 92 patients, and we prospectively measured endotoxin using the endotoxin assay, which classified the patients in 3 levels of endotoxemia: low endotoxemia, medium endotoxemia, or high endotoxemia. And you can see on the graph that the level of endotoxemia was associated with a higher occurrence of post-cardiac arrest shock. Furthermore, the level of endotoxemia was associated with the short-term survival of the patients, and you can see that patients with a high level of endotoxemia in dotted line had a very low survival, dying from refractory post-cardiac arrest shock in the first days after return of spontaneous circulations. However, all of these data are biomarkers, so they are not direct evidence of gut lesion, and they do not give information about the mechanism of the digestive tract injury. That's why we performed a prospective multicenter study, the ANTRACT study, which is recently finished. It was performed in 9 ICUs in France and Belgium, and it aimed to define the incidence of upper gastrointestinal tract ischemia after out-of-hospital cardiac arrest, performing systematically a gastroscopy between day 2 and day 4 after ICU admission. The main exclusion criteria was to be extubated at day 2, and of course, patients that have died before day 2 could not be included in the study. So overall, we included more than 220 patients. 214 had their gastroscopy as planned in the protocol. And the main result of our study is that 121 patients, so more than 50%, had at least one ischemic digestive lesion in the gastroscopy. The picture shows you the localization of this lesion, and fundus was the main localization. These lesions were severe, defined as ulcer or necrosis in 45% of case. This busy table shows you the patient's characteristic according to the presence or not of digestive ischemic lesions. And you can see that, surprisingly, no flow and low flow times were very similar between both groups. In median, 5 minutes of no flow and 20 minutes of low flow. Conversely, the epinephrine boli during the CPR were higher in the patients with ischemic digestive lesions. During the first 2 days in the ICU, there were few differences between these patients. Lactate level at ICU admissions was similar. We observed differences, surprisingly, in hematocrit value and chloremia value, but not on the frequency of vasopressors use. By multivariate logistic regression, we were able to identify predictor of digestive ischemia. And you can see that beside peripheral arterial disease and pump proton inhibitor used before cardiac arrest, we identified 3 potential modifiable factors, namely the epinephrine dose during CPR, the chloremia during the 2 first days in the ICU, and the hematocrit that were associated with the presence of digestive ischemia at the following gastroscopy. These lesions, however, were not associated with post-cardiac arrest shock, which concern roughly 2/3 of the patients, as published in other reports. And this was not different also regarding severe lesions comparing to mild lesions. Conversely, the survival without sequelae, evaluated by the CPC score, was clearly lower in patients with severe digestive ischemia lesions, as shown in these survival curves, with a p-value of 0.04. So in conclusion, we can say that cardiac arrest induced a gut injury with ischemic reperfusion mechanisms. This injury is associated with endotoxin translocation. Upper digestive tract lesions are frequent, roughly 1 patient out of 2, and severe in half of these patients. Keep in mind the main limits of our study, that the most severe patients, which died before day 2, as well as the less severe patients that could be extubated before day 2, were not included. These lesions of the upper digestive tract were not associated with shock. However, severe digestive lesions were associated with worse prognosis in all the studies I've shown you. So this brings to a pathophysiological hypothesis that ischemic reperfusion injury induced intestinal injury, endotoxin translocation, which adds to the endothelial ischemia reperfusion lesion to induce the production of pro-inflammatory cytokines, the development of post-cardiac arrest shock, and this shock may worsen the digestive injury, increasing the endotoxin translocation and making the patient in a vicious circle. Of course, the study that I have spoke are just association studies that do not demonstrate causality. But if there is a causality, we identified potential modifiable risk factors. Clearly, the epinephrine dose during CPR, which is very controversial, and also markers of hypovolemia, the increase in hematocrit and the decrease in chloremia, that may worsen the mesenteric perfusion. And maybe we should take care of optimized the hemodynamic of our patients following the return of spontaneous circulation. There is a potential place for adjuvant therapies, but we should, of course, evaluate them before using them. For instance, endotoxin removal or digestive selective decontamination. Thank you for your kind attention, and enjoy this special congress.